Professor, Physician, Epidemiology. I am Dr. Sri Banerjee. Hello everyone, I'm Dr. Sri Banerjee, core faculty for the College of Health Sciences and Public Policy at Walden University. This presentation is about EKG interpretation. This is not for the faint of heart, no pun intended, but this is the version 10, 2017-2018 version. And this has some really important components. So the reason I am lecturing anything about this, first of all, I've actually read this book quite a few times back in my days of training, and I actually took the ACLS exam from studying this, and also various other exams. So this is definitely a book that I have known very well. But a lot of this has to do with taking a look at some of the various aspects of EKG interpretation and how complex this can get. So I wanted to provide an appreciation of the complexity of this. So you do have, of course, arrhythmias like atrial fibrillation and atrial flutter, but there's so many other types of arrhythmias out there, including VFib, including some variants here, some that you might have heard of, others that you might not have. Additionally, there's clinical disorders that cause arrhythmias. So when we're thinking about arrhythmias and the epidemiology of arrhythmias, make sure that you are, for instance, going beyond what is normally investigated or researched. Look beyond that, because there's quite a few that's out there that are important. Atrial fibrillation does take place very commonly, so many times when you're studying chronic diseases, that might be one arrhythmia that you might, at the very least, take into consideration. But there are just so many out there. At the very basic level, each wave is representative of 0.2 seconds. So each little box is 0.04 seconds, and so the 0.2 comes from multiplying 0.04 times 5, so you have 0.2 seconds in each big box. So then you have the PQRS T wave, the PR wave, the PR interval, which is atrial depolarization, and then the QRS, which is the ventricular depolarization. The ventricular depolarization is way higher than the atrial depolarization due to the fact that the ventricles are much more muscular. If you were to draw this out right quickly, you would quickly see that the ventricles are actually a lot bigger than the atria. And so if this were the atria, then the ventricles, in fact, would be this. And so, for instance, this is the mitral valve right here. The valve between the atria, the blood rushes into the atria from the pulmonary vein, and then from the pulmonary vein into the left atrium into the left ventricle, and then this is where a lot of the heart failure problems occur, in the left ventricle, because a lot of times this is just becomes tired of pumping blood out to the whole body, because this is the one chamber which is responsible for pumping blood into the whole body through the aorta. And so the blood comes out of the aorta, and then, of course, supplying blood to the axillary artery, uh, the brachiocephalic, um, the carotids, and then the subclavian arteries. So blood is flowing to all these different places. And so any sort of disruption in that blood flow causes either, if it's the carotids, if it would be causing a stroke, and any sort of arm, with the subclavian artery. So these arteries are going places, and actually one of the early branches, coming out of the left ventricle, is going to the coronary arteries. So the coronary arteries are blood vessels which supply the actual heart. And so when you're having a myocardial infarction, what's happening is that the blood vessels, and I'm going to make the blood vessels a different color actually, just so that you can see it. The blood vessels in the heart, they're getting compromised for whatever reason. Maybe there's a clog somewhere in the heart. And so because they're getting compromised, there's something called atherosclerotic plaque that's getting accumulated. There's not enough blood supply, so pretty soon what happens is there's a restriction of nutrients that's going into the tissue of the heart. And so when there's a lack of oxygen and a lack of nutrients to different parts of the tissue of the heart, this deprivation then causes necrosis. And so tissue, what that is, necrosis is basically, that's tissue death, because there's not enough nutrients. And once that tissue death starts to take place in the heart, that is what is causing an infarction. So an infarction is basically a clot in a major vessel in your heart, which is causing stoppages and the inability for nutrients to get to the places where they need to get to in the heart. That's what an MI is. That's what a myocardial infarction is. And many people understand heart attack. Many people understand myocardial infarction, but they don't understand exactly the pathophysiology that is going on behind that. And it's important to be understanding kind of what is going on, because then you can ask the right epidemiological questions. For instance, then you understand healthcare utilization, what types of medications may be needed in order to treat a myocardial infarction, and what types of healthcare utilization took place afterwards. So there's a lot to it, and in fact, knowing that, along with what are the diagnostic types of steps that you take, that that is kind of a crucial point to be thinking of as well. For instance, initially, EKGs are the go-to for kind of a checkup. And then after that, the next level is typically considered an echo, an echocardiogram, sonographic images of the heart. And then the next level is typically known as a heart catheterization. So placing a dye and visualizing the heart. So understanding also the diagnostic tests, because then once you know the diagnostic tests, then you can answer questions about positive predictive value, increasing the predictive ability, how that affects positive predictive value, negative predictive value, some of the epidemiological considerations that are so crucial to understanding cardiovascular epidemiology. So the appreciation that I'm trying to impart here today, here in this video, is that cardiovascular epidemiology is way more complex than just knowing about morbidity and mortality, cardiovascular related mortality. It's not enough just to know that 700,000 Americans lose their lives each year from cardiovascular disease. That's not enough. That's only the surface. You have to then go into the risk factors. You have to go into additional conditions, cardiovascular conditions that are important. Some that may be more crucial. Some that are not as crucial, but also some that are seen more frequently. Torsade, for instance, torsade de point is a waveform that is seen frequently as a drug side effect. So that's one a lot of times that is studied in research studies. So it's not just about the chronic condition. Chronic conditions have many different components. As it turns out with cardiovascular disease, you even have an EKG that you could be interpreting. Electrophysiological studies actually, I can show you data sets that are available of p value of p waves, QRS complexes, which you can then use to run analyses. So this goes through a lot of the lead placement. It's a really good book to be going through. I've been through it so many times. And it goes into how to think about arrhythmias and conduction disturbances in a kind of systematic manner. And so when you think about the first thing that you think about is the electrical impulse. So you think about that, and then you kind of move into the formation versus the conduction in the formation. Where is it going on? Is it in the atrium? Is it in the AV junction, the ventricles? Is it normal rate? What is the regular? So you see, these are giving you ideas. So maybe you want to study all irregular heartbeats, and maybe not just your atrial fibrillation. Maybe you want to just study tachycardia. See, so these are all different types of formation. Onset is passive escape or active, which is important. Now conduction, is it sinus node? Is it atria? The AV junction. Is it Winky-Bach or Mobitz type 1 or type 2? What type what type of heart block is it? So you typically, and I'm not gonna draw the heart again. I'll draw it one more time, just for the sake of illustration. But typically you have an SA node that starts off about right here, and then from the SA node you have, and I'm going to use different colors for illustrating the nodes here, but you have the SA node, and then the AV node. So you have conduction, electrical conduction that you're dealing with. The last part of the lecture, I was describing to you the blood flow in the heart, but now it's electrical conduction that I'm explaining to you. So electrical conduction, SA node to AV node, and then from the AV node, you have these electrical impulses then go up like that. So there's like a bundle of His. So that's impulse formation. That's there you have it. There's descriptors of impulse conduction, and I'm not gonna again, I'm not gonna go into a lot of these. Sometimes, but these are ways that you can kind of organize your arrhythmia research. This is going into more into, for instance, A flutter is another one that's seen frequently. So you can kind of look at the site of origin, if it's in the atria. Sometimes PACs are studied. At what point? So here's a question. Here's a good question actually. At what point are PACs considered AFib? At what point does ectopic atrial rhythm turn into AFib, atrial fibrillation? And so these are some of the questions, some of the research questions which are important to ask. And how about rates? How does how does atrial fibrillation in the phase of tachycardia differ from atrial fibrillation without tachycardia? And similarly, in ventricles, you can ask similar questions. PVCs. Remember, I was asking about torsade. That's an additional one. VTAC and VFib. So already we have gone over quite a few different types of arrhythmias, probably more than what you cared to know about. Here's some additional ventricular arrhythmias if you want to study a little bit more about it, but otherwise, here's the reasons that you would be seeing this. Something about digitalis toxicity, which can cause this as well, but not really necessarily seen today as frequently. But here's the Purkinje network, and here the bundle of His and all the electrical impulses that I was trying to draw, but not as good as the one that is in this book. So I'm just gonna scroll through this book, make sure that we didn't miss anything, but there's another opportunity to study something unique. These AV blocks, these tend to have a tendency to take place as well. So another place to study. For considering anything in cardiology or any sort of sciences in fellowship, this is really a good book to be familiar with. It's only 91 pages, so it's really not too bad. And here's one way to determine left ventricular hypertrophy. Again, another condition that can be studied pretty easily. And this is actually a scoring criteria which allows you to determine when something is considered hypertrophy. Here's myocardial ischemia. So at what point does myocardial ischemia become myocardial infarction? Time is muscle. So that means that when basically before cellular death takes place completely, if there's thrombolytic sort of treatment that or percutaneous revascularization that takes place, and then things can be prevented. So when somebody is taking some sort of acute coronary syndrome, the Ecg recognition is quite important. So basically, a sudden reduction of coronary blood flow to regions of the ventricular myocardium takes place when there's an atherosclerotic plaque or some sort of thrombus formation. When there's a plaque that's eroded or ruptured, or thrombus is formed. So if you get thrombolytic treatment, if there's no necrosis, then long-term damage may not occur. It also depends on the two types of MI. So one is that has troponins, elevated troponins, with an ST elevation MI, and one is without ST segment elevation. Q waves can be there in either one of them, but if there's enough revascularization again, then long-term damage can be prevented. So this is another area of public health, because then healthcare services and the rapidness, or the, should I say, the speed with which treatment is received makes a difference. Here's some differential diagnoses, and then some additional abnormalities, some T-wave abnormalities. I think we end with torsade U-wave abnormalities, and that covers everything. So in 20 minutes, we've covered a 100-page book. So hopefully you've learned some things about cardiovascular epidemiology, especially in the field of arrhythmias. Quite a few things. If you want to check out more things, here's some resources as it pertains to arrhythmias and atrial fibrillation. Thank you for listening.